Greetings, I'm Keith Horvath, and I'd like to talk to you today about payment bundling. As we make the transition from volume to value-based care, it's important to understand the various reimbursement models that allow that change to occur. As you may be aware, with different types of payment methods, there's a relationship between what the provider takes on with regard to risk and what the payer can achieve with regard to savings. In a purely fee-for-service, volume-based system, the risk for the provider is very low, but then the savings that the payer can achieve are equally low. The other end of the spectrum, in full capitation, the provider is taking on the majority, if not all, of the risk, and at the same time, the payer can therefore achieve significant savings. Bundled payments are sort of in the middle along this spectrum, and they're important, therefore, to understand, particularly because the Center for Medicare and Medicaid Innovation, CMMI, has been using bundled payments for some time now as a reimbursement method. One of the largest programs, the Bundled Payment for Care Improvement, or BPCI, has now been extended and expanded as BPCI Advanced. This particular program will continue until the beginning of 2024, and it includes 35 different episodes. And for each of these episodes, the provider is responsible for the total cost of care over 90 days, following that inpatient hospital stay or following that procedure or operation. Because the savings are contingent on cost and quality, it does meet the criteria for an advanced APM. And episode initiators can be either physician group practices or acute care hospitals. Recently, CMMI has made a number of changes to BPCI Advanced, and one of these is demonstrated on this slide. They've taken those 35 different episodes and rearranged them into clinical episode service line groups. So in the past, you could participate in any of these episodes individually, but now, if you're an institution, for example, that's in percutaneous coronary interventions, whether it's inpatient or outpatient, you will then also assume the rest of those episodes in the cardiac procedures super bundle. So it would include coronary bypass grafting, valves, TAVR, defibrillators, pacemaker, no longer just PCI. It's an important change that has occurred. But methodologically, how does this all work? Well, CMMI uses 3 different ingredients to create an episode target price. They look at the hospital's baseline performance based on claims that have been submitted over a historic period of time for patients undergoing those procedures or for those stays in the hospital. They then adjusted the results based on the peer group in which that hospital resides. Is it a rural or urban hospital? Does it have an academic medical center, or is it of a certain size with regard to the number of beds? All of these different criteria end up delineating the various peer groups. And then risk adjustment is achieved by looking at the comorbidities and adjusting based on the patient case mix for each of these episodes. And they take all 3 of those ingredients and come up with a benchmark price, after which they take their discount. 3% is taken right off the top. So they guarantee that CMS guarantees the savings to themselves for each episode. The product of all this is a target price. So named because if you come in under that, that's what you're aiming for. That savings that you achieve under the target price, keep. If you are over the target price, that overage needs to be sent back to CMMI. This is an example from real data as to what that looks like for participants that have won or lost in this particular BPCI Advanced. And what these 2 charts show are actual data, claims data from patients, and each one of these represents a different patient and the episode. The dashed line, the orange line that you see going across, is the target price. So there's depicted the institution on the up graph. For most of the patients, they were under that target price and therefore were able to achieve savings. In contradistinction, the graph on the lower part of this slide demonstrates an institution that didn't achieve savings and actually had some losses, which they then had to repay. And why was that? Well, the blue and purple that you see that's fairly fixed across the bottom of both graphs represents the inpatient index admission as well as the professional fees, which are largely unchanged. Where there is a difference is in the post-acute care. The bottom graph shows that there is yellow for almost every patient, which represents their use of home health on almost every patient. And as well, for about half patients, the use of a skilled nursing facility is depicted by the green bars. So immediately, you can see where that post-acute care network and utilization thereof becomes very important in success in these types of bundled payments. I mentioned that quality is a significant part of BPCI Advanced. Another major change that has occurred, which is very important to Society of Thoracic Surgery members, is the incorporation of the STS database into this model. These give you a few of the quality measures just for 2 different episodes for cardiac valve and coronary bypass graft. And starting in January, participants can choose whether they want to submit quality measures along an administrative set of quality measures or whether they want to use an alternate quality measure set. The administrative set is primarily based on claims. The alternate quality measure set is based on not only some claims, but also registry data, and specifically the Society of Thoracic Surgeons Adult Cardiac Surgical Database. This is the first time that that database and the outcomes that you have achieved via that database are now tied to a reimbursement system from CMS that I think is very important for folks to understand. As we conclude, it's critical to know that there are a number of components of value-based care that allow for opportunity for savings as well as care improvement. It's absolutely essential. The clinical champions are involved with all of these various types of episodes and even more so with the creation of these super bundles. People that understand what is necessary for the kids need to be involved in the decisions that are made and how the institution or the group participates in these bundles. The ties to post-acute care networks now become increasingly important because, as you saw, a length of stay in a skilled nursing facility now may have more importance and more impact on the overall results than the length of stay for that index hospital admission. Care management across that 90-day episode, also very important. This is a little bit of a change based on what had occurred under a fee-for-service system. And maybe even the most critical piece is understanding those care transitions. When you move as a patient from an inpatient setting to the post-acute care space, making sure that that transition either to home or to a skilled nursing facility or an inpatient rehab, that needs to be coordinated and understood by all involved. And those are the keys to success for savings in BPCI Advanced. You may ask, why do I need to understand this now, since it's our choice where we want to be involved? Well, one of the other announcements from CMMI was that at the end of BPCI Advanced in 2023, beginning in 2024, this type of a bundled payment system will be mandatory. So it may be important to understand how this is going to work for you before it becomes a mandatory system.